Well, I'll be talking basically about the treatment in adults. Uh, we do know that 50% of osteoarticular tuberculosis is the spinal tuberculosis, and the classical variety is paradiscal. However, you get skip lesion to about 7%, and if it remains untreated, it leads to quadriplegia, paraplegia, or grotesque deformity, as we saw in the last lecture. The principle of treatment of tuberculosis basically remains a medical treatment. You see, it's a medical disease, and anti-tubercular drugs form a sheet anchor of treatment. However, the main problem remains in the duration of the anti-tubercular drugs that we need to give. However, there are no conclusive studies that are available to resolve this issue. It has varied from 6, 9, 12, 18 months, but however, at our center, we make an effort absolutely to give this treatment at least for 12 months in all our patients. Earlier, the enforced bed rest has been one of the basic things along with the treatment. However, presently, we prefer to have functional treatment where the forced complete rest is usually not favored unless fusion is the aim, and we allow movements once pain is reasonably under control with the help of braces. Now, majority of early disease, they respond very favorably to a non-operative functional treatment. The essential drugs remain the first line of drugs: INH, rifampicin, pyrazinamide, streptomycin, ethambutol, and thiazolidine. And the second line of drugs have been the aminoglycosides, thioamides, fluoroquinolones, and cycloserine. We've been using atypical DOTS regime, however, and the principle has been that we use INH, rifampicin, streptomycin, ethambutol in the initial phase, which controls a fast multiplying bacteria, and that later on it is being maintained with the continuation phase at least for 9 months. However, till date, we have no drugs available for the dormant stage of tubercle bacilli. DOTS regime has been the most popular in our region. This concentration of these drugs in the various tissues have been found to be absolutely therapeutic, and we have been able to assess them in the serum, and then in the abscesses and in the joint cavity. A tuberculosis of spine that presents without a neurological deficit, they are uncomplicated cases. There, the conservative treatment or treatment with relative bed rest, drugs, and later ambulation with braces gives an excellent cure rate to a rate of 85%. Another method, which has MRC controlled trials in their 13th report have also shown that when these two methods were compared, the Hong Kong method where there has been extensive radical debridement anteriorly with fusion and drugs, the cure rate has been almost 89%. There has been no significant difference between the cure rate in cases without neurological deficit, that is uncomplicated cases. So what are those cases which are most suitable for conservative treatment? Classical two vertebral disease with a destruction where there is less than 50% of the vertebral height is destroyed. There is no neurological deficit, and on MR picture where you find that the cord is relatively preserved, there may be an edema of the cord or extradural fluid. Classical example, you have a classical example right here showing a bone marrow edema, softening at the paradiscal margins of the vertebral body, patient on anti-tubercular treatment, and complete healing seen in 8 months' time. Complete healing of the vertebrae seen in 8 months' time with the reconstitution of the vertebral body. Another example of an active disease in the cervicodorsal region, and a complete resolution of the disease, and in about 9 months' time. And this is what it shows on a CT scan. You have a destructive changes right at the cervicodorsal region, and with 9 months anti-tubercular treatment, the patient has complete restoration of the vertebral body, and a healing with sclerosis has taken place. So tuberculosis of spine with neural deficit, we try to put them in a category, in 4 categories. That is the 4 stages, where it's stage 1 where the clinical features are more or less negligible, where the patient is unaware of his deficit, and when he comes to the clinic, we find that there is a definite upper motor neuron signs. In mild cases, the patient is aware of deficit and walks clumsily with support, and you have definite neurological deficit. Well, moderate cases, the paralysis is roughly with extension, with the limbs in extension, and the sensory deficit is more or less 50% or less than 50%. While in severe cases, it's a flexor spasm, patient presents with flexor spasm, and more than 50% of deficit with sphincteric involvement. This gives us a guideline to prepare these patients for surgical decompression. Now, there are certain definite indications for early surgical decompression in these patients, where there is extradural compression, and we find there is a granulation or a caseous material. Very little fluid with edema, there is evidence of myelitis or myelomalacia, or there is a sequestrated disc that can be observed very well on MR. So MR remains a sheet anchor for diagnosing these cases wherever there is a neurological deficit. Or those patients who have developed, or there is no improvement when the patient has been on anti-tubercular treatment, or there is worsening of the neural deficit in conservative treatment. Or a patient who has got an acute onset paraplegia with severe grade, or paraplegia with neural arch involvement, or a panvertebral, a global disease with or without subluxation or dislocation. Here is an example of a sequestrated disc which could not otherwise improve until unless we have done an early decompression at this mid-dorsal region. There would be some cases where we would definitely need instrumentation. So as we define, what are the situations where we need to instrument these spine? Those cases which have panvertebral disease, or the long segment disease, where the length of the bone graft that we need to put after a decompression is more than equal to 2 vertebral bodies, or wherever there is kyphosis of more than 30 degrees, or in correction of kyphosis. This is an example of a panvertebral lesion. This is panvertebral lesion. There is no way. There is a highly unstable spine, and we need to instrument it and fix it. Or in severe kyphosis where it needs correction. So there are certain clinical features which will tell us about, which will prognosticate that these patients are better for recovery and these patients are possibly poor for recovery. For those patients who present to us with paraplegia, which is partial 1, 2, and 3 grades are possibly better, and those with complete paraplegia are the poor ones. The duration, if it is shorter, if early onset, if it is slow, the speed is slow, if the patient is relatively young and general condition is relatively good, and there is an active vertebral disease as well, and kyphosis is less than 60 degrees, and where the MR appears, the cord appears to be normal on MR, that there is no evidence of myelomalacia, and a lesion is wet where it is an abscess. It's a better indicator for good prognosis. Where you find a dry lesion or there's already a presence of myelomalacia, they are really poor indicators for recovery. So we have an algorithm for treating these paraplegias where they are started with anti-tubercular drug, rest, and roughly around 3 to 6 weeks. And if you find it is progressive, neurological improvement, we continue medications and allow walking when recovery is complete. If there is no recovery, they go in for a surgical decompression. And in those, after decompression, if there's a progressive neurological recovery, after 3 months, they start ambulations. And those who have shown no neurological recovery, we put them for a repeat MR or a myelogram. And in those patients, if we find there is a block, mechanical block, we repeat a surgical decompression, and if there is a neurological recovery, they continue medication and permit walking when recovery is complete. If there is no recovery, then they go for rehabilitation. And if you don't find a block, that means there is no mechanical obstruction to the neural tissues, and there must have been some intrinsic damage to the cord that has occurred, and we continue medication, however, in these patients, and later they are rehabilitated. So what remains in future for us is that we should have specific markers for early diagnosis in treatment of tuberculosis. We could possibly, we could achieve some we could achieve advancement in drug delivery with nanoparticle encapsulated anti-tubercular drugs, where we could have enhanced bioavailability and reduced hepatotoxicity. And of course, what we need to do at this stage as well is to define the endpoint of therapy in these patients. Thanks very much indeed.
Thank you, Professor Kumar. Well, now I'll make